Okay, thank you for asking me to come. So I'm going to try to give you some ideas as to how to reconcile what seems a contradiction, and that is weaning and giving patients sedatives. But I do think there actually is some role for this, and so we'll touch on that in the next 15 minutes. I don't have any conflicts. So there's, as you all know, many studies suggesting that sedatives impair liberation from mechanical ventilation. I don't need to go into all that. So what business would we have giving sedatives to a patient who's having difficulty liberating from the ventilator? Often these are patients that are distressed, agitated. So I guess the first thing I would say is make sure that sedation is actually going to remedy your problem of a patient who's having difficulty liberating from the ventilator, and just show you some examples where clearly the problem is not the sedative or the lack of sedative, but it's the tube too far in, not far in enough, or perhaps there's some other tube that's in the wrong spot that certainly could make a patient agitated. This is my favorite. I'm not quite sure how the intern did this, but he put the Dobhoff tube into the trachea down the left main stem, did a 180-degree turn, came back to the crine and went down into the right main. I don't think you could do that again if you tried, but that patient was agitated, and the solution is not to sedate the patient. Or this patient who has subtle, but if you look closely you can see this patient with status asthmaticus has bilateral pneumothoraces. So the first thing when you're dealing with a patient for whom liberation is not going as you might plan, and the reason is distress or agitation, and you're inclined to reach for a sedative, is to make sure you're not missing something that might be occult. But sometimes sedation is necessary to facilitate weaning, for sure. And this is one of the papers now from a decade ago, Marlene DeWitt's work, and she did a study at Richmond where she asked the question if we could stop sedatives every day. And what she found was a surprise, which is in her population, not only did it not work, patients actually did worse. And if you read in her discussion, she talks about her population, a high incidence of substance and alcohol abuse, and a high incidence of patients who were very agitated when the attempt to liberate, awaken, and get the patient off the ventilator. So this is important to bear in mind because sometimes our patients behave this way. This group, Stephanie Goddard and her group actually looked at what do we do, at least in the Canadian critical care setting. And I found it interesting that during the extubation assessment, half of the patients, only half, had no sedative infusion. Meaning that while we might say we should stop the sedatives in an attempt to liberate patients from the ventilator, in point of fact, that doesn't always happen. And this is a paper from 2016, so you might ask yourself the question, why is that? Well, I think there's what I would categorize as prototypical patients who might be particularly in need of a bridge, if you will, or something to stem the distress that comes during the awakening and breathing exercise. Young patients, patients with certain types of respiratory failure. My experience has been, and this is mostly what I'm showing you on this slide, is my anecdotal experience, but patients with ARDS or status asthmaticus in particular, and then those patients that have a history of substance abuse. These kinds of patients can be extremely difficult to manage. So one option might be to say, well, just use opiates. Let the patient breathe. Let the patient attempt a spontaneous breathing trial, a weaning attempt, but keep the opiates on. Thomas Strong's group published this Lancet paper in 2010 showing that morphine only on an intermittent basis was associated with shorter ventilator days, shorter lengths of stay, suggesting that, and he called this no sedation, and I think that's true, but I think the concept of sedation needs to include analgesia as well as traditional sedatives. Here's a remifentanil to facilitate spontaneous breathing trial. And what you can see here in the areas that I've circled is that what remifentanil did in these patients who were tachypnic during a spontaneous breathing trial was reduce their drive to breathe, reduce their respiratory rate. Now, at first pass, that might seem counterintuitive. We want to get the patient off the ventilator. Giving the patient a drug that impairs their drive to breathe could be counterintuitive, and indeed it could be. But if it helps the patient to facilitate through this process, we'll talk about this in the next session, the weaning exercise is far from perfect. We're trying to make an assessment based upon the best parameters that we know, recognizing that the weaning trial, passing or failing, however we declare that bivariate outcome, then leads to a next bivariate outcome, which is I remove the endotracheal tube or I don't. And those are your options. And so if the patient is tachypnic, if the patient is having increased work of breathing, in this study it was respiratory rate, it was esophageal pressure swings, so we can infer, and there was a probably not clinically significant, but statistically significant difference in auto-PEEP. That perhaps slowing the respiratory rate down in certain populations of patients who are tachypnic could be beneficial. This is particularly relevant now that we have drugs that we can give that have such short half-lives that we can titrate effectively. Here's some very early work in status asthmaticus from Tuxen and John Marini, and the concept of auto-PEEP and this dynamic hyperinflation. These kinds of patients during spontaneous breathing trial with some degree of airflow obstruction or a substantial degree, and an endotracheal tube that is a source of distress may actually benefit from breathing slower. What about dexmedetomidine? There's a drug that's relatively new, but it's been around long enough now that I think most of us have some familiarity with it. And here's a JAMA paper from 2 years ago in agitated patients who were getting propofol, randomized to getting dexmedetomidine or placebo as a bridge, as a facilitator of spontaneous breathing and extubation. You can see that the patients who got dexmedetomidine were able to be extubated more quickly. This is, the drug is attractive because it does not suppress the drive to breathe, and so you can actually extubate your patient and maintain the infusion if you deem that to be of some benefit. Here's another respiratory care paper, and you can see the same message, facilitating extubation in a SICU population who had failed previous weaning attempts. This is a pilot study, but nonetheless it suggests that there may be some role for dexmedetomidine. Here's a mixed population of patients. This is Yahya Shahabi's work. And this group of patients who were very agitated were then given dexmedetomidine. And what you can see is that they were able to transition to a target level of sedation with very little, in fact, no over-sedation. So this is black bar times 0, first black bar, and you can see that as we go to 6 and 12 hours, there's a frame shift where patients go from very agitated or agitated to much less so, thereby facilitating you as a bedside clinician in trying to decide, what do I do with this patient whose mechanics, whose gas exchange, whose circulation, whose mental status, whose airway protective reflex all seem intact, but when I try to let the patient breathe spontaneously and take away the sedatives, become very distressed. Same message from this is Massimo Antonelli's group, mixed population of patients, and dexmedetomidine was used to facilitate difficult to wean patients. So I think we have a reasonably robust body of literature suggesting that dexmedetomidine may be valuable. This is a critical care medicine SCCM abstract that I did not see has gone to full publication, but this group of investigators asked the question for that group of people who are difficult to manage. So in a chart review, they were able to get the vast majority of them extubated when they sedated them and proceeded with the spontaneous breathing trial. There's a study here looking at antipsychotics, and so loxapine, and there are, of course, other antipsychotic drugs that are available. One of the attractive things about these drugs is also, like dexmedetomidine, they don't suppress the drive to breathe. Sometimes I'll use the phrase to take the edge off. So these medicines are able to take the edge off for some patients who become distressed. And we've all seen these patients. And sometimes to continue to try the same exercise only to have it fail puts you in a conundrum where you might say, sometimes the right thing to do is maybe just trial extubate. Of course, that's unsettling because it's potentially risky and you're making a best guess. So these drugs like dexmedetomidine and the antipsychotics can help to facilitate this transition. In conclusion, it's important to remember that certain patients may require sedation during weaning. The first thing to always look for is to make sure that your endotracheal tube, your enteral feeding tube are not malpositioned, particularly the endotracheal tube up near the vocal cords or down at the carina is a recipe for distress. And then make sure there isn't something that you didn't anticipate, like a pneumothorax, like a mucus plug that has given you whole lung atelectasis. These are kinds of things that could be remedied with a simple intervention. And then the population of people for whom this type of process may be useful, the ones, in my experience, generally young. I often see it more in men than women, and that might just be because muscle mass is generally greater in men and they tend to become more physically agitated, at least as the bedside observer can see. And then the population of patients with ARDS and status asthmaticus in particular. The air hunger that comes with these disease processes for some patients is extraordinary. And so I think opiates in particular can have a role in trying to facilitate that transition from full ventilatory support to partial to spontaneous breathing. And then knowing your population. If you have a patient who has a history of substance abuse, in Chicago we have a huge problem with heroin. And so if you have a patient who has a known heroin addiction, to take away all opiates during the spontaneous breathing trial is probably going to be a counterproductive intervention. So I'll stop there. Thanks for your attention. You probably have time for a question.